So once we understand getting the drug into the body, we can then turn our attention to another major question, which would be how much response do we get when the drug is present? So in this segment, we'll connect the dose, the response, safety, and receptor binding, and some of the early signaling concepts into our understanding. So with dose response, we can connect concentration to response. So a dose response curve reminds us that the response does not increase forever. In other words, it's not a linear relationship. So just because the dose increases doesn't mean we'll get a continued maximal impact. There's a ceiling or a maximal response. So once you get close to that ceiling, taking more drug may increase the concentration, but not provide much additional benefit. So on the figure below, what we see is the EC50, and that refers to the concentration that's made its way into the body that's accumulated that produces half of the maximal response. Now, alternatively, we could use the term ED50, and this is slightly different because this isn't the concentration that's built up in the body, but rather this is the actual dose that we're taking. So ED50 refers to the dose that produces half of the maximal response. Now that distinction matters because the dose consumed and the concentration achieved, they're related, but they're not the same thing. And as we know, there are certain factors that might play a role with the amount of drug being consumed and whether or not that drug is being sequestered or stored, or whether it's being secreted, perhaps secreted at a more rapid rate than we're anticipating. So this is quite helpful for us to keep this in mind. And of course, the figure that you see on the screen is all about the maximal response of the drug. So keep in mind that it's not a linear relationship, but what we're observing is at some point, right, even if we have a more and more and more concentration, we don't tend to see any additional maximal response. Now, the therapeutic index is one of the most important safety concepts in pharmacology because this tells us how close the effective dose is to the lethal or severely toxic dose. And so ideally, the effective dose is far, far away from the dangerous dose. And that would mean that the drug has a wide therapeutic index. So when the therapeutic index is narrow, then small shifts in concentration can create major problems. So this is why narrow therapeutic index drugs require more caution and closer monitoring and more consistency in dosing because the safety window is simply smaller. Now, a very important consideration for drug prescription is how close is the effective dose to the lethal dose. Okay, so if we look at the figure on the right, that represents a very scary drug. Because to get an effect of the drug, we have to consume nearly the lethal amount of the drug for it to have its intended effect. But that's, of course, not ideal. Now, the drug represented in the figure on the left is much safer. So notice the effective dose is much further from the dose that's lethal. And then take note in our check marks at the bottom, we want a therapeutic index of fourfold or more. And it's necessary to consider that when a patient is taking, let's say, 50 milligrams of a certain drug, right, is what they've been prescribed, we need to know how reliable that dose is based on the manufacturing of the drug. In other words, are the companies really providing what they say they're providing? So perhaps a patient takes a dosage of a generic drug brand and it doesn't have any effect or it doesn't work, right? When the patient takes the same dose of the brand name medication, it works. Well, in this example, it may simply be an issue with the manufacturing of the drug. So we need to verify that what we think we're consuming is actually what we are consuming and that the intended dose is in response to what we believe we're getting based on the recommendations or the prescription of the physician. Now, once the drug is in the system, right, it has to bind in a meaningful way. So this is where we really need to understand receptor binding. And receptor binding is usually not permanent. In fact, that might be dangerous if it latched on and wouldn't let go. And so that non-permanence is a good thing. We want the drug to bind to create an effect and then also to come off so the system can keep regulating itself. So the strength of the interaction depends on the kinds of bonds that are involved. And it also depends on the potency of the drug, which reflects how much drug is needed to produce that effect. So when we really are talking about receptor binding, what we're really talking about is the strength of binding, the reversibility, and also the effectiveness of that interaction. Now, ligand binding is not permanent binding. In fact, it's weaker binding, which allows the ligand to go on and off the receptor. And as I mentioned, we don't want ligands to stick to a receptor and stay for a long period of time because then it's difficult to regulate the on and off periods of that drug. So when we look at the potency, right, um, we have to consider that potency is the affinity of the drug for a receptor. So do we get the max effect with 2 milligrams of the drug, or does it take 100 milligrams of the drug? See, with 2 milligrams of the drug, we have a more potent drug. So less drug in the bloodstream is going to have a profound effect. Now, most of the things that drugs interact with, they're proteins. So receptors and ion channels, etc. Now, there are certain AIDS and HIV medications which do require a patient to first undergo a blood test for certain enzymes because enzymes tend to facilitate and speed up reactions. And we have to understand if certain enzymes are present or absent, well, then it may change the way the drug interacts. So if the enzyme is present, then they may not be a candidate for a certain drug because it won't work due to the nature of, let's say, preferential binding or the enzymes which initiate a change in the affinity or they cause a mutation of the drug. So this particular enzyme is present. When we give this drug, it's going to change the drug and the drug's not going to have that intended effect. So most of the time for other drugs, right, the patient isn't screened and the will it work criteria doesn't tend to be a dominating factor. So oftentimes physicians are prescribing drugs based on what generally happens. Now, binding is only the beginning, right? Because the signal has to go somewhere. And signaling mechanisms are often receptor mediated. And once a receptor is activated, then the cell can alter the enzymes. Ion channels and transcription or secretion, right? This can all be adjusted. In other words, the single binding event can cascade into much larger physiologic responses. And this is one reason why side effects occur. So the receptor might be the intended target, but the downstream signaling can influence more than one tissue or process. So when a drug works, it's often working through a signaling network, not necessarily a single isolated event. And we see some examples there at the bottom indicating the types of endogenous signaling, so whether it's an autocrine, which is secreting a substance that feed back on itself, or paracrine, where it's secreting a substance that acts on some cells nearby, or as you're most familiar from the endocrine system, right, we have endocrine signaling mechanisms whereby a cell secretes a substance, it's carried through the bloodstream and usually acts at a cell that's at a distant site. So the um, hormone or medication or in this case the signaling has gone and circulated through the blood to get where it needs to go. So the main idea here is that the drug response is not random. It depends on the dose, the reception and the receptor interaction, and it also depends on the signaling and whether or not we have to consider safety might be dependent on its therapeutic index. So more drug does not automatically mean more benefit, And that point continues to show up in pharmacology. So we want to keep in mind as we're working with patients, right, and we're getting this discussion of whether they're taking the medications, how much of the medications, if it's a new medication, right, all these questions have to be asked to help us to better understand what's going on maybe on the background of the response for the participant.